Hello and welcome to Inside Exercise. I just had a really quite remarkable and really interesting chat with Kathryn Schmitz from Penn State University, who is a leading researcher in cancer and exercise. She has a remarkable background and has been involved in many guidelines on cancer, exercise, survivorship, etc. If I was to sum up the podcast, I'd go with what Kathryn said, which is in regards to exercise and cancer, it's good news and good news. Exercise reduces the chances of getting cancer. It improves outcomes during treatment. It reduces the chance of getting cancer again. And it also improves the mental state of people with cancer. It was clear that similar to diabetes, cancer is actually a metabolic disease. And indeed, Kathryn became interested in exercise and cancer research after being involved in metabolic type research. She mentioned that even though 80% of oncologists realize part of their job is to talk to people about exercise, only 14.7% do. Unfortunately, most of us have been touched by cancer in some way. So I think this is a really important podcast, and you may indeed suggest it to some family and friends. Enjoy it. Hi, Kathryn, how are you?
I'm great. Nice to be with you.
Oh, good. All right. So I often wonder about, how do people actually get into the field, the research they're doing? With you, was it like an interest in cancer, or was it like did you have an exercise background, or how?
Yeah, so actually I'm on my third career. And my first career was as a professional classical dancer. And I was not interested in eating ramen noodles forever for the rest of my life, and decided to get into fitness training. And got into that and was a personal trainer in New York City for a number of years, and decided to get a master's because I thought I would make more money as a trainer. And, I come from a family of academics, and I was, really bound and determined not to be one. I clearly failed miserably in that attempt, but so while I was getting my master's, I had the opportunity to work on a research study. And I thought, I'll just figure out what it is my siblings do as researchers. So worked on a research study and thought, wow, this is it. This is what I want to do for the rest of my life. So I got sucked in to the academic enterprise, and my doctorate was actually not in exercise and cancer. My doctorate was with Dr. Art Leon, who's most well known for research on exercise and lipids. He's a cardiologist, or was a cardiologist. And so my dissertation was about exercise and metabolic disease and heart disease. I was interested in obesity prevention. I did a lot of work in epidemiology. And so I was doing a postdoc in cardiovascular epidemiology. And, I was aware of the fact that a lot of the really, really big movements forward in the field had already been made, that the giants in the field had already discovered all of the amazing things that are the basis of how we train people now. And so one of my mentors, Kristen Anderson, said, have you ever looked into possibly working on exercise and cancer? And I thought, well, I could spell cancer, I don't know anything about it. So I went off and read, and, I did like you do as a postdoc. I spent 3 weeks reading the literature, and there wasn't that much to read because it was a brand new field. And among the papers that I read was a single paper that changed my career. And the paper was a call to action, and it was published either 95 or 99, can't remember. First author was Ann McTiernan from the Fred Hutchinson Cancer Research Center. And what she proposed was that people with exactly my kind of training, who were, focused on metabolism and obesity and diabetes and obesity prevention and heart disease, that we turn our attention to exercise and cancer, because our skill sets would be so useful in the area of oncology. And I took up the call. I wrote her an email out of the blue, and she, called me, and we set up a time to meet at a meeting. And she gave me 2 of her grants to read, to say, here's example grants for, in the field. And I wrote my first grant to the Susan G. Komen Foundation. I got it. I never looked back.
hang on, just something there. You wrote your first grant and you got it. That was not my experience. Well, that's a very interesting background there. And you know, it sort of suits me because I'm a metabolic guy. So you know, getting into metabolism by a cancer via metabolism just means you're probably thinking about things that I want to bring up today. So that's great.
Yes.
All right. So no doubt, you know, been interested in obesity and diabetes and things like that. You've thought a lot about how lifestyle diseases contribute to cancer. And I think I saw you tweeted something a few days ago about, you know, 4 out of every 10 cancer cases is preventable lifestyle related. Is that right?
That's absolutely true. Yeah. Now, what's interesting is that the lifestyle factors that are most associated with cancer, just so that your listeners are very, very clear about this, actually have more to do with tobacco and alcohol. And to a lesser extent, physical activity and obesity are in the mix as well.
Absolutely. Yeah. I mean, that's obviously a very important point. I think we all think of tobacco and cancer, but
right.
You know, it's maybe not so front of people's mind to think, oh, I need to be physically active, you know, lose weight, eat well, whatever.
Mm-hmm.
So I guess, I mean, we're here to talk about exercise. And I guess, why don't we set the scene? So, you know, we spoke a couple of days ago about how we're going to go about doing this. And you said, you know, sort of chronological order, primary prevention. Did you want to just take us through that as just to sort of set the scene, and then we'll get into the...
Sure. So when in cancer research, in order to kind of organize your thinking, it's sometimes helpful to think about the cancer control continuum. And what I mean by that is you can think about primary prevention, which is to say, you know, what is it that causes cancer? What are the, you know, we can have a conversation about, you know, exercise and primary prevention of cancer. And then, you know, as we get closer into diagnosis, once somebody's been diagnosed, there's a sliver of time often before they start their treatment when there could be an opportunity for prehabilitation. So we can have a conversation about the value of doing exercise between the time period between diagnosis and starting treatment. Then there's a whole different set of interests and reasons we would care about exercise and why we would ask people to do exercise during their active treatment. During active treatment, we're much more interested in people's psychological well-being and their ability to, you know, withstand the treatments that they're undergoing, their ability to get done what they need to get done in their lives without undue pain and suffering. And then when they're done with all of their treatment, then there's a recovery period. There's, you know, rehabilitation, you know, the you know, improving body composition and function and cardiovascular exercise becomes extremely important there. And then, of course, there's the long run. And if we think about, you know, in the cancer control continuum, there's 2 trajectories, right? One trajectory is things didn't go well. And then we're talking about, you know, potentially long-term treatment for people with advanced cancer and potentially palliative care, hospice care, and the end of life. The other trajectory, of course, is long-term survivorship. And in that case, what people worry about most really is that cancer going to come back, right? So there's a whole field that is focused on exercise and secondary prevention of cancer or prevention of death from cancer in people who've already been diagnosed. So cancer control continuum kind of walks us through the process from primary prevention all the way through end of life.
Wow, there's a lot there to think about, of course. What sort of jumped out at me was, you know, I was sort of thinking about exercise itself is having these positive effects, but you also said, you know, that potentially the positive effects psychologically of exercise as well. So it's interwoven. So I guess reducing anxiety or...
Yes, we actually have really compelling evidence to tell us that exercise is quite useful for both anxiety and depression. During active treatment in particular. And, you know, something like 40% of patients present with either anxiety or depression as they're going through treatment. Stop and just think about it. You know, think about, you know, that, you know, if you were going through cancer, wouldn't it be fairly common to be pretty anxious about that? And exercise is well known to be helpful for abating anxiety, and it's very helpful in this particular situation.
It's such a horrible thing to be talking about, isn't it? In some ways, it's just so difficult. So, I had Ben Levine on just, a few days ago talking about the heart and exercise. And it's something where you can sort of think, oh, yeah, maybe my heart's going to get, have problems later in life, and maybe I shouldn't be eating this or whatever. But cancer sort of feels so sort of final, and you know what I mean? It's well, it's obviously not final, and that's what you want to talk about, but it's scary.
It is scary. And it feels like an existential threat. The diagnosis feels like an existential threat. That said, for many common cancers, our ability to survive them for 5 or more years is well over 50%. For breast cancer, early stage breast cancer is, survival to 5 years is over 90% at this point. So, so there are types of cancer that have become, in essence, chronic diseases.
Yeah. And I guess, we've all been touched. I can't help because I started getting a bit emotional then, because my mother died during COVID in New Zealand, and I couldn't get over there because of lockdowns. We were the most locked down city in the world. And she was diagnosed with 2 to 8 weeks to live. And it was right at the start of COVID. So I couldn't, I booked and then I had to cancel, and I booked and I had to cancel. It was also right at the start. So people didn't have the set up so you could do Zoom and FaceTime and all that. So I literally saw her twice before she died. So I think everyone's sort of been touched by this.
Yep, me too. So my wife was diagnosed with head and neck cancer 3 days after she moved into my house. So we were fairly early in our relationship. We weren't married at the time. And she had stage 3 squamous cell carcinoma in her right nostril. And they kept telling her, during that rehabilitation period, they were like, we're going to take the tip of your nose. And she, they kept saying tip of your nose. And she finally said, all right, draw for me what the tip of the nose is. And they drew the whole nose.
Oh, no.
And that's when the penny dropped. That's when she was like, okay, you're removing my nose. And they actually labeled the surgery that she had a complete rhinectomy, which is a very formal way of saying, got your nose, literally,
It doesn't translate the tip of nose. No.
Right.
Yeah.
And so she had her whole nose removed. She had a forehead flap, which interestingly is a surgery that was invented in ancient India, because one of the punishments for a thief in India was to remove their nose. So they invented a surgery in India thousands of years ago, where they took a flap of skin from the forehead and twisted it down and made a makeshift nose. And that's actually what they did. So she had this massive surgery with all this, she had skin grafts and bone grafts, and, it was obviously more advanced than what they did thousands of years ago in India, but we were completely overwhelmed. I was a complete deer in headlights. I still remember the moment, like, she was done with surgery. She had recovered from her surgery, and she was starting chemo and radiation combined. And, and she said, oh, I'm just so tired. And something finally, like a bell went off, and I went, wait a minute, I can help with this, and I suddenly, like my training, like, I woke up and went, oh, I know what to do. I can help with that, And so, so I got her going with the treadmill and got her, made her exercise every day. She didn't like it very much, but I made her do it. And my God, she is part of like a small subset of head and neck cancer patients who get through combined chemoradiation without a hospitalization, without needing a dose change. She sailed through. It was hard, but she managed to get through the whole thing. I will tell you that being the primary caregiver for someone with an advanced cancer, and especially a weird advanced cancer, like in the nose, that's not a common cancer,
Yeah.
It has forever changed the way that I see my work. I do things differently. as an exercise oncology professional and researcher than I would have prior to that experience.
Wow. Okay. So, okay. Well, that's, I'm glad it sounds like there's a happy ending. I didn't know how it was going to end.
She's 5 years out.
Oh.
She's 5 years out and no evidence of disease. So.
All right. So if we get, I guess I was thinking about, you know, I did some reading before this and I saw how, you know, I guess it wasn't that long ago. I don't know how long ago, but they always say if you have cancer, then you've got to, don't do any exercise. You've got to save your energy and whatever. When was that? And when and how and when did we go from now? I saw something written yesterday saying, you know, every person with cancer should do some exercise. I don't know if that's the case, but how did that actually, how did we get from there to here?
Right. So, so the history is a fun story. I had the great opportunity of writing a history of exercise oncology for the first chapter of my first book, Exercise Oncology. And it's, you know, that book, by the way, is the one that is for academics. You know, I have other books for other audiences, but so the first chapter was intended to be kind of, well, where did we come from, right? So the first study that I was able to identify that I think is relevant to exercise oncology was actually from 1911. And it was an epidemiologic study that showed that in the you know, mechanization of society, the Industrial Revolution, the people who were still manual laborers were less likely to develop cancer, and they were less likely to be obese. Yeah. So it was noticed that more labor, more activity seemed to be good for cancer incidence. So that was interesting. That's a long time ago, you know. Then in the 1930s, there were a couple of 30s and 40s. There were a couple of animal model studies that were quite notable. One from the Wistar Institute in Philadelphia, and they kept using exercise as a stressor for the animals because they wanted to show that the stress of exercise was very bad for you and that, you know, that it would cause cancer. So they had these animals and they would, you know, inject them with a carcinogen and they would exercise some of them. And what they kept finding was that the animals that exercised were less likely to develop the cancer, or that the tumors wouldn't grow as large, or as, you know, it would take longer for the tumor to develop. And so they finally, you know, concluded, oh, you know, maybe there's actually something here. And, you know, we kept learning that lesson because, you know, the cultural zeitgeist was that exercise was stressful and you shouldn't do it while you have cancer. You know, finally, our first human clinical trials in the area of exercise oncology happened in the late 1980s. And they were done by nursing researchers at Ohio State. And they were very symptom oriented. They were, you know, interested in if we exercise women who have breast cancer while they're going through treatment, what happens to their body composition and how does their fatigue do and how's their anxiety, you know, questions like this. And they were all very, very positive, very small studies. In the 1990s, there was, you know, reviews of the entire literature of, you know, 4 clinical trials, you know. By the time I wrote the first meta-analysis in this area in 2005, there were 22 high quality randomized controlled trials. 2010, there were probably 200 randomized controlled trials. And, you know, by the time we did the second ACSM roundtable in 2018, there had been an exponential 281% increase in the number of randomized controlled trials. So this field has just exploded since the year 2000.
Wow. Okay. So when you think about all these studies, obviously there's going to be a big difference in them. Some are going to look at prevention of cancer. Some are going to look at exercise during cancer. Some are going to look at what I want to talk about later, like things I've seen about, you know, having it during chemotherapy or between doses of chemotherapy or whatever. So how about we start going through that? So, you know, how good is the evidence that exercise reduces the likelihood of getting cancer to start with? And one thing I was thinking about was Ben Levine said the other day, they looked at the Olympic athletes from 1896 through to 2010 and showed that they had, you know, less heart disease and more longevity. Has anyone ever done anything like that, for example?
Yes. So actually, we don't really look at Olympic athletes because there's honestly so few Olympians that end up with cancer, and I actually have a project ongoing about that particular issue.
Okay.
But you'll have to ask me about that later because I want to answer your question. I think there have been two really fantastic epidemiologic umbrella reviews that have been published in the past several years that have looked at the issue of whether exercise is prevented. Whether cancer is prevented as a result of doing exercise on a regular basis. And what we're able to conclude is that exercise does reduce the likelihood of incident cancer for 7 different common cancers, including breast, bladder, colon, endometrial, esophageal, renal, and gastric cancers. So for all of those cancers, we fully expect that there's a 10 to 20% reduced likelihood of onset. Now, why those 7? Those are the ones that we have the data for. So there is some modest evidence that actually we can reduce risk of lung cancer, particularly in non-smokers, with more physical activity. But for the cancers that we don't have the evidence, it's mostly because we don't have the studies. So it's more a lack of studies than the studies say, no, there's no effect.
Actually, can I jump in? Yeah, that makes sense. Can I jump in there? Just, you said physical activity. One thing I often think about, and it's part of the stuff we've done with our sort of rat studies, is saying how much is the inactivity and how much is exercise. So for example, people usually do studies with rats and mice where they go, okay, put the rat in a cage, just sits there and does absolutely nothing, which is just crazy, sedentary, unphysiologically sedentary, because these rats and mice usually run around 5 or 10 Ks a day. And then they get them to exercise. So you're comparing crazy sedentary to their often forced exercise. So what, and then you start saying, okay, let's include a running wheel. So then you've got sort of normally active versus whatever. So you kind of need inactive, sedentary, and then you need normally sort of active. So maybe doing, just normal activity. And then you need exercise training. So I'm wondering, it's a bit long-winded, but I'm wondering how much of the prevention of cancer or the reduction in risk is just going from being like sedentary to sort of normally active, and then how much is going from normally active to like exercise training, going out and trying to, I don't know, run 5 Ks a day or whatever.
Yeah. So these are seen in the field as separate variables. Sedentary behavior and lack of physical activity is seen as a risk factor that is, interestingly, independent in epidemiologic literature from, and much like you were just talking, as compared to being more physically active. And so we actually do have evidence that tells us that that being inactive is a risk factor for the development of cancer, separate and over and above, and in addition to the 10 to 20% risk reduction that we expect to see for people being adequately physically active. So and what we mean by this is, the variable is completely possible for somebody to be adequately physically active and sedentary at the same time, because it could be that they are very sedentary in the rest of their day, and they go out for a run for a half hour once a day, right? And so those two things can coexist. There also are people, though, who are just active throughout their day. They're, the FedEx workers, who are just up and down and carrying things and moving things all day, right? So they may not go out for a run for a half hour. They might, I don't know, but let's say they don't. But those people are physically active and they are not sedentary. So they're really distinct variables.
Sorry, so the FedEx worker who's active all day, do they have and that, what if you've got the FedEx workers that are active all day, and then you've got the FedEx workers who actually go for a run 4 days a week?
That's the ideal. That's the ideal. That is the ideal. And so what we hope for is somebody who is adhering to the physical activity guidelines and who is not sedentary. And, you know, I can tell you, I am that physically active sedentary person.
Oh,
That's me. You know, I adhere to the guidelines, but I also sit, you know, at my desk most of the day.
actually, I'm happy to say that I've just put together 140 days of exercise, but the best run I've ever had. Well, it's not run. I used to be a runner, so I'm going to be careful saying run because I can't run. But 140 days of cycling in a row.
Wow.
Yeah.
Wow, that's impressive.
That's
That
the
is
best of it.
impressive.
But then again,
But were you sitting the rest of the time?
probably.
You are.
I
Exactly.
do walk my dog a couple of times a day, but okay. So
Exactly.
then we start thinking about mechanisms, I guess. I mean, you know,
Yeah.
how is exercise actually reducing the risk of cancer?
Right. So when we think about this, what we can start to think about is the, you know, the process of the development of cancer, right? So a lot of things have to go wrong for cancer to develop, a lot of things, right? So the first thing that happens is some kind of initiating event, you know, exposure to UV radiation, exposure to tobacco smoke. No one in exercise oncology believes that exercise or lack thereof is an initiating event. We don't think that's where the power is for exercise. But then once you're past the initiating event, you have proliferation, you have progression, and then you have things start to, like the ball keeps rolling and you keep growing this tumor and things keep going badly in a worse and worse and worse way. And so you end up with a multiple hit hypothesis, right? So what are those hits? And one of the major things that we know will be very, very comfortable territory for you. It has everything in the world to do with fat. It has to do with fat. It has to do with the fact that fat, if it is in the body and not being used on a regular basis with cycling 140 days in a row, then we start to develop these crown-like structures that are like macrophages that hang out around our fat cells. And that starts to attract immune cells, and that starts to attract all sorts of pro-inflammatory factors. And all of that dysregulates what's happening with insulin, and many, many factors just start to get, you know, very, very much changed in the way that we're using our fat cells, the way that our fat cells are living within our environment. And if you happen to have,
sorry. So are you saying, because I'm not a cancer, but I know how to spell it, like you said at the start. But, are you saying that the cancer usually starts in fat cells with macrophages? No. Okay.
No, what I'm saying is that all of this dysregulation creates a great deal of inflammation and a great deal of oxidative stress. And because you've got all of this inflammation and oxidative stress, all of this is happening in tissue pockets all over the body. And if you happen to have a little baby tumor that is thinking about forming, and it's sitting in this particular soup, then it is potentiated, then it grows.
Well, it
grows because it's in a microenvironment that potentiates more dysregulation. Okay, so the fat that is sitting around and not being used for exercise on a regular basis is different than the fat in a body where you are exercising on a regular basis. And because these crown-like structures start to accumulate around the fat cells, it dysregulates all of the metabolism in that area. And the thing is, that fat is everywhere. It's everywhere across the body, okay? And so the likelihood that something that is thinking about being a tumor is somewhere near that dysregulation of all of the metabolism and what's happening with upregulation of leptin and downregulation of adipokines, of adiponectin, I'm sorry. All of those things are happening right next to where something is thinking about it. It's thinking about becoming a tumor. And if you're putting it in that particular kind of microenvironment, then it's potentiated to more likely become a tumor.
Now, I guess it's more complicated than this, but is that partly why people that have higher fat levels, obese people, etc., have higher levels of cancer?
Yes, it is. But one of the things that's a little confusing and very important for me to say is that that epidemiologic evidence that I gave you earlier, that exercise reduces the likelihood of incidence of 7 common cancers, is independent of obesity. Okay. So, and you are an exercise physiologist, you will understand extremely well the difference between, you can be a thin person and have and be sedentary and have these crown-like structures and have fat globules that are like behaving badly, So our body composition is what is vitally important here. And the quality of our fat tissue, the quality of our muscle tissue makes an enormous difference for the microenvironment in which a tumor would potentially grow.
It's incredible how similar this is to the stuff I tend to think about more with diabetes.
Exactly.
Because, medical doctors often say, well, the reason exercise is good for diabetes is because, you lose weight. And I say, well, yeah, that's absolutely true. But an acute bout of exercise increases your insulin sensitivity for 24 to 48 hours, right?
Yes, in fact, I think that don't we have plenty of evidence to tell us that it may actually be the acute effect that's more important?
Yeah, it looks like it's a bunch of acute training belts is it sort of adds on a bit, but it's largely the acute. And it's the same when you're talking about the fat being, whether it's turning over or not or whatever. So it's the same in the muscle. We talk about muscle fat. And if the muscle fat, so athletes have high muscle fat, but it's fine because it's getting turned over and whatever.
Exactly, it's being used. It's not surrounded by. Yeah, it's not inflamed. So the fat that's not getting used on a regular basis, the lean adipose tissue, if you will, lean adipose tissue. Does that make sense to you?
I know.
Yes, to you. Okay, so lean adipose tissue. So this is tissue that is anti-inflammatory. This is adipose tissue that is being used on a regular basis for fuel, that is there and is healthy fat that the body needs in order to function, to make cholesterol. This is normal, healthy fat. This is different than the excess fat that we can carry around that can be pro-inflammatory.
Okay. Now, I know that, when we talked a couple of days ago, we talked about how I was saying, well, is it with diabetes, they have increased risk of cancer? And I was saying, is it the elevated glucose? And you said, well, it's more sort of the insulin. So can we talk about that a little bit? Because again, we know exercise increases insulin sensitivity. And is that part of the way that exercise is protected?
Yes, it's exactly back to the exact same soup that I was just talking about. The tumor microenvironment is altered by, if there is excess insulin that is pro-inflammatory. And if there's more insulin, then there is likely more oxidative stress as well. And all of that is going to increase inflammation. If the inflammation is going up, then we're going to have more crown-like structures in the fat. If we have more crown-like structures in the fat, then there's more immune cell infiltration. The immune cell infiltration just sort of jacks everything up again. And then there's an upregulation of cytokines, downregulation of adiponectin, upregulation of leptin. And again, it's the ingredients in this. I like to think of it as ingredients in the soup, So the insulin, the insulin inflammation crosstalk is what is so vitally important. And as well as I do, that exercise has a powerful effect on insulin. And so it is the effect of exercise on insulin that we think, if we had one biomarker, if I had to choose one biomarker that exercise changes very reliably, that would have to do with the development of cancer, it would be insulin.
Okay, that's really interesting. I knew that cancer sort of has a metabolic basis to it, but I didn't realize how, I just have to sort of cross out diabetes and like cancer almost to understand it. So you mentioned something about it's not the direct effect of the exercise, it's more the secondary. So it's not the effect of the exercise isn't sort of, while you're exercising, you're getting heat shock, you're getting warm and you're getting heat shock proteins activated and you're getting changes in adrenaline and whatever. It's not the actual direct effect of the exercise, it's the effect the exercise has on other things such as insulin sensitivity, etc. Is that right?
Yes, that's exactly right. That's exactly right. So by being more active on a regular basis, then you're changing the way that your adipose tissue behaves, the way that it's organized, and you're changing the level of inflammation in the adipose tissue. You're changing levels of myokines as well, so that the muscle tissue is changing as well.
Just to clarify,
but again,
myokines are things. So when you exercise, there's various proteins and things released from the muscle. So they're called
correct.
Yep,
Exactly. So we know much less about the myokines in cancer than we do about cytokines, adipokines. So those are things that are much better studied. The other thing that we haven't touched on that is related to this soup, if you will, are sex hormones. So we do know that exercise can have regular exercise, training exercise can have an effect on estrogens and androgens, and that is going to have a powerful effect on the relationship with that will alter the relationship with insulin as well, the way that insulin will behave, and what tissues are taking up insulin. So there's potentially mediating, I'm not sure if it's mediating or moderating effect of the effect of exercise on sex hormones that alters everything that we've just been talking about.
We'll get back to these sort of sex differences later. What I was thinking about there was you were talking about the sort of soup, which may be involved with making like a little tumor, a few tumor cells become cancerous. But what about once you've got the cancer? So if you've got a cancer and it's growing, okay, then what happens then with the exercise? You're rubbing your hands together. What happens then with the exercise? How does that affect that situation?
Well, one of my very favorite mechanisms to talk about with this is, it really goes back to what I was studying as a doctoral student. I was interested in exercise and the cardiovascular system. And so, what does that have to do with cancer? Well, it turns out that tumors, once they have developed, are really disorganized, and the blood vessels leading to tumors are very tortured, and it's not a patent tube, getting to the tumor. It's messed up. It's got lots of sprouts off of it, and it's if you were trying to drink lemonade, you wouldn't want that straw, if you will. And so what we know from exercise and heart disease research is that exercise causes shear stress. And so they've now applied this in the setting of cancer.
Just to clarify, shear stress is so when you're exercising, the blood's going through and it's sort of pulsating and it's causing this sort of shearing on the blood vessels. So which
changes the blood vessel, which makes the blood vessel more patent. It improves our blood vessels. And so one of the reasons why exercise is good for our vascular system is because exercise causes shear stress. We know this. This is something that's been around. It's so old, you'll have a difficult time finding a paper about it. You'll have to find it in a book somewhere, That's how long we've known this. But now we've applied it to cancer. There's a researcher at MD Anderson in Houston, Texas, by the name of Carrie Shadler, who has done what I think is just brilliant work in this area. So she's taken all of these animals with various different kinds of cancer, and she knows that the tumor is there, and she's taken a look at the vessels, and the vessels are just tortured and messed up, and then she exercises some of the animals and doesn't exercise other animals. And then she looks at the vessels again. And what she finds is that, in fact, shear stress is working. And it's causing the vessels that get to the tumors to be more patent, more open. And exercise is doing what we know exercise to do to a vessel. It opens it up, okay? And why is that a good thing? It's a good thing because then you're better able to deliver the chemotherapy. And so the animals that exercise and have the greater shear stress have smaller tumors at the end of the experiment because they've been given chemotherapy at the same time they're getting the exercise. And the combined effect of exercise and chemotherapy is causing the tumor to shrink more quickly than in the animals that get chemotherapy and no exercise. And the mechanism behind this is the good old-fashioned effective exercise on the shear stress, which is opening up the vessels to allow the chemotherapy to get to the tumor.
Well, at first I was thinking, improving these vessels and opening them up is going to get more nutrients to the tumor. So I guess what happens there, because I know you're talking about the chemotherapy getting to the tumor, what happens in the group that does the exercise alone?
Yes, they do see an effect. So if you look sort of, think about a graph and think about, the size of the tumor, how much does the tumor grow over time? The tumor grows the most in the animals that get nothing, the tumor grows the least in the animals that get combined exercise and chemotherapy. The tumor grows less in the animals that get exercise only, but it grows a whole lot less in the animals that get chemotherapy only. But it is best. Things are, the outcomes are best when you combine.
This brings up something. This brings up something I was going to ask later, which is often people aren't going to feel like exercising, right? When they've got cancer, when they're having chemotherapy. But with the animal studies, I guess you just throw them on the treadmill. So what I wanted to ask you there was, if, often you say, well, do it, think about exercising within the pain limits, or the way it makes you feel, and if you don't feel like exercising, have the day off or whatever. How does that work with a cancer patient? I guess it depends on the cancer, the stage of it, whether you're on chemotherapy or not. But is this the sort of thing where you go, no, listen to your body, or do you need to sort of push through that to get the benefits?
Depends on the outcome you're looking for. So we do have clinical guidelines. There is a guideline from the American College of Sports Medicine. There is a guideline from the American Society of Clinical Oncology. There is a guideline from the Clinical Oncology Society of Australia, COSA. So, there are about 8 or 9 clinical guidelines now that are out there for what we should be doing. And ACSM, I think, is the most specific. And the recommendation during treatment is 3 30-minute sessions of moderate intensity aerobic exercise per week, plus twice weekly strength training during treatment, and then 150 to 300 minutes a week of moderate to vigorous intensity activity for prevention of recurrence. So that's after the treatment is over, and twice weekly strength training. So the question of how do you manage your symptoms in the midst of that exercise prescription is a good one. I think my answer to that question is quite different now than it was before my wife had cancer. As a researcher, I'm going to tell you that we need to dose exercise. I mean, there are researchers in exercise oncology who are doing personalized exercise oncology, who are saying, okay, let's give 60 minutes, 90 minutes, 180 minutes, let's give these very specific doses of exercise, to people who are going through their cancer treatment. The challenge of doing something like that is that the reality is that the person is dealing with cancer as a whole human. And, there are going to be bad days. There are just simply going to be days when you can't do the exercise. And so I've written about this in a popular press book called Moving Through Cancer. And one of the things that I think is important in that book and sort of concepts behind that book are that it's exceedingly important that people, on the one hand, recognize that they're going to have bad days, but on the other hand, that because they had a bad day, that is not a reason to stop exercising for the remainder of time you're going through treatment. That, if you have a bad day, okay, tomorrow get up and try to do something. Every day, try to get up and do something, right? And so by virtue of doing that, by virtue of attempting to do something every day, you will find the days when you can do something.
Perfect. Okay. Now, the other thing I've seen written here and there was the prehab. Yeah. So the like cardiovascular disease again, before you have a heart operation, you try and get the person a bit fitter. Is it the same with cancer?
Yep. So the American Society of Clinical Oncology has actually just come out with a guideline that includes advice that there should be pre-surgery, pre-treatment exercise to improve function and outcomes in a variety of common cancers. I believe lung was one of the main ones that they named in that particular thing. It's a guideline that is easy to find. Go look for ASCO exercise guideline. Just Google for that. But yeah, so rehabilitation has been studied a lot as well in colon cancer, much less interestingly in breast cancer. But where it's been looked at, it does appear that we can reduce the amount of time that people are in the hospital. We can reduce healthcare utilization. We can improve pain outcomes after surgery, reduce the amount of pain medication that people need to take. There are a variety of different clinical outcomes that are improved if we do anywhere from 2 to 6 weeks of rehabilitation. And, you know, the problem is, if you've got a tumor that really needs to come out, you're not going to wait. So the amount of time that somebody has is very, very different. Now, in more socialized medicine societies, where people do have to wait for their surgeries, rehabilitation is a no-brainer. So, for example, in Canada, people have to wait a little longer for some cancer surgeries, and that is the society that should embrace rehabilitation.
Perfect. All right. So, what about lifelong exercises versus someone? Do you have that sort of breakdown? So, someone that's been like exercising for, you know, doing the prehab or for a month or two or whatever, versus lifelong sort of exercises. How's the prognosis differ?
Yeah. So there's good news and good news. So the good news is that lifelong exercise is a great idea and is helpful for reducing risk of incidence of cancer. But the other good news is that there is evidence to show us that if you've been a complete couch potato, done nothing, had cancer, survived your cancer, and start exercising, that there is a really, really potent effect of exercise for reduction of mortality from your cancer for breast, colon, and prostate cancers on the order of 30 to 50%, which is pretty substantive.
Wow. So there's good news and good news. Okay, that's nice. So is there, I guess I start wondering, obviously not everyone that gets cancer and does all the right things, does exercise, etc., is going to pull through. Do we know why, you know, some have the positive effect and some don't? And another thing, I guess, is depends on the cancer. That's the thing I often wonder about. You know, you think, oh, this study looked at breast cancer, this study looked at whatever cancer. Is cancer, or does it depend on the type of cancer?
Yeah, cancer is I mean, even breast cancer is many different diseases. It's not a single disease, and you know, it really should be cancers, you know, because there's so many different kinds. Even like I said, even breast cancer is cancers. You know, it's multiple diseases.
Okay.
The way they develop, the drugs that you would use to address them, the surgeries, the you know, risk factors, the you know, people who are likely to develop these diseases are all distinct. They are as distinct as diabetes and heart disease, and more so even. You know, the genetics underlying these diseases are highly separate and distinct. There are some hallmarks of cancer. It's kind of more like a system, if you will, rather than a disease. It's sort of a, you know, the cancers hang together on the basis of about 10 hallmarks. Please don't ask me to name them. And you know, but you know, would you call them all the same disease? That it's difficult to even call them the same disease.
Okay, so it's so complicated. And I guess another thing to throw in the mix there is this sort of sex differences, which you touched on earlier. Did you want to just elaborate on that a little bit?
Sure. So obviously there are, you know, very, you know, specific cancers that are going to occur just in women and cancers that are going to occur in men. But in addition to that, there are 4 cancers that occur in both men and women. There do appear to be an important role for estrogen, for example, in the case of colon cancer. So colon cancer is quite likely a distinct disease in men than it is in women, often a different disease in men than it is in women, or can be. And one of the reasons that it can be is because of the influence of estrogen. So, you know, so there are a number of cancers that, you know, as I said, are, you know, highly sex specific, but even among, you know, even lung cancer, the way that the cancer behaves and the way that you're going to go about treating it could be distinct according to the gender of the person that you're treating, and whether, not just that, but also whether the tumor is responsive to hormones, which could be distinct, not just in breast cancer, but in other cancers.
Okay. The other thing, I guess, is genetic. So how much of the genetic influence is there on the likelihood of getting various cancers? But also, is there any sort of genetic sort of interaction with exercise? Do you think that some people, you know, may respond more than others, or?
Oh, absolutely. So the answer to your first question is cancer is 100% genetic, and cancer is likely very little genetic, all at the same time. And what I mean by that is that the way that cancer develops is by breaks in DNA, which is your genes. So it is by default, by definition, because of what it is and the way that it develops, it is a genetic disease. That said, the reason the DNA break happens in the first place could be because of UV radiation, because of the sun.
Right.
Okay, because of an environmental exposure. It could be that the reason why the DNA break happens in the first place is because of tobacco exposure or some kind of other environmental exposure, right? It could be something to do with the diet and some toxin in diets, right? So it could be that even the initiating effects or initiating step for the start of the development of a cancer is not genetic. It could be environmental. It could be very well be environmental. That said, there are certainly people who have a particular genetic predisposition for the development of cancer. The most famous of these, of course, is the BRCA genes for the development of a number of different kinds of cancer, most famously breast. So in those people, we talk about the multiple hit hypothesis, and you know, they have a mutation in a gene that is exceedingly important towards the, you know, development of breast cancer. So they've already had the initiating event simply by being born, right? And so they only need one more hit before they start tumbling down the road. So the likelihood in somebody with certain types of BRCA mutation carriers, the likelihood of the development of cancer can be as high as 80% in their lifetime. So there is quite a broad spectrum of how important our genes are. And in keeping with that, there's also then quite a broad spectrum of the likelihood that exercise is going to be particularly helpful to you. So I actually was a research assistant on the Heritage Family Exercise Study.
Oh, wow.
Which was all about,
Okay.
yes.
Well, Paul Bouchard's coming on soon, so that's interesting.
Yeah. So there you go. So so you can ask this very question. I want you to pose this question to him, okay? Because it's a great question. What is the genetic variability of our ability to respond to exercise? It's going to be the same for cancer as it is for heart disease. It's going to be the same for other things. And I think that there's a tremendous variability in the same way that, you know, I mean, there's variability in our you know, genetic makeup for cardiovascular fitness, right?
Yeah.
So, you know, I was born with a really crappy engine.
Oh.
I run really slow, you know. That's what I got. You know, so you know, but does that mean that I am incapable of being trained? You know, so there's sort of, I had this genetic predilection to a poor engine to start with, but what is my capacity to grow that capacity, right? What is, am I trainable? So that trainability, I think, is a really, really excellent question. And I think Heritage started to answer that question. But personally, I think it just was the tip of the iceberg.
Well, you know what? Yeah, so we'll talk about that. The thing, you know, I think most people are trainable, even if it might take more, but that's another discussion. But you know what? I've been thinking about how you said it's good news and good news, and every aspect we've talked about, exercise has been good. Now, what makes me wonder is, do doctors actually push exercise enough? My fear is maybe they don't. But you know, I read something yesterday. They said if the effects of exercise could be encapsulated in a pill, it would be prescribed to every cancer patient worldwide and viewed as a major breakthrough in cancer treatment. So what do you think of that?
Oh, I couldn't agree more. And there's a paper that just came out this year. Jennifer Ligabell led an effort from ASCO to do a survey of patients in order to ask, you know, how often does your physician refer you to an exercise program? And 14.7% of the respondents said that their physician referred them to an exercise program during their treatment.
That's terrible.
That despite the fact that she did a survey a few years ago that showed that about 80% of oncologists, medical oncologists, said that they knew that it was part of their job to talk to their patients about exercise. So clearly we have a mismatch, and you know, I don't want to make the doctors wrong. You know, they're very busy, and there is actually a dearth of medical oncologists right now, and it's just going to get worse. So we need to develop an infrastructure to make it easy for the oncology care team to connect patients to exercise training, you know, during and after cancer treatment.
Well, the other thing is we just need to get people watching this podcast, yeah?
Yes, exactly. There you go.
All right, so that's fantastic. So I sometimes, I don't always remember, but I like to say at the end, you know, how do we sum up this? And this one just feels like the easiest one to sum up ever. There's just there's good news and good news. Yeah, I mean, is that for exercise and cancer? Like before, during, I guess we haven't talked that much about the likelihood of, you know, getting cancer again. That's reduced as well, is that right?
Yes, it is. In particular for breast, colon, and prostate, about 30 to 50% reduction of cancer-specific mortality for people who've had those cancers if they are regularly physically active.
Wow. Okay. I found this like just really, really interesting, and I'd like to go longer, but people say keep it, don't go over an hour. So we're close to an hour. So if people want to know more or whatever, do you feel comfortable with people contacting you? I don't know, on Twitter or?
Sure. You can find me on Twitter. I'm at Fit After Cancer on Twitter. And my easiest email to find me is Dr. Kathryn Schmitz at gmail.com.
Okay. Well, thank you very much for this. I've really enjoyed it.
Thank you.
Thanks. Bye-bye.